All right, our next presenter is Shirisha Avadhanula. Dr. Shirisha is a program director and former enterprise medical director for Inpatient Virtual Health at Cleveland Clinic. And she has many more other things, so I'll let her start.
Thank you so much for the time, and I think you're the first person in the history to ever pronounce my name correctly. I appreciate that a lot. This is Blue Door Health, and this is my story. My name is Dr. Shirisha Avadhanula. I am a board-certified endocrinologist and internist. I trained at Georgetown and then the NIH. I was the enterprise medical director for Inpatient Virtual Health for the Cleveland Clinic Enterprise. I am an advisor for multiple digital health startups, and I am the founding leader of one of the only internal medicine residency programs in one of the most underserved areas of this country. And I currently lead that program as their program director. My journey from the second best institution on this planet to one of the sickest and most rural pockets of this country has led me to create Blue Door Health. My intention is to take clinical and academic excellence and channel it into a place, finally, that actually needs it. You don't need an endocrinologist to stand here and tell you that millions of patients suffer from obesity in this country. There are still, consistently to this day, obesity-related comorbid conditions like heart disease, stroke, cancers that kill millions of Americans and remain one of the top killers in this country, and not to mention the deep financial burden that it causes on our health system in the multiples of billions. The statistic is that 2 in 5 adults suffer from obesity. That leads us to about 100 million patients. For those 100 million patients, there are about 9,000 specialty providers in the United States that can provide services to them. And that's not even the tip of the iceberg. Numbers is not really our issue. Our problem is that consistently, every year, through surveys in this country, medical residents are not adequately trained on obesity medicine and nutrition. And that leads to insufficient care for our patients for chronic disease management. And for patients in rural areas, this problem is even more pronounced. Patients in rural areas suffer disproportionately from obesity and obesity-related comorbid conditions. And specialists in rural areas are few and far between. It is very difficult to recruit specialists in rural areas. And just to give you some perspective, our waiting list just to see one endocrinologist is about a year. If you compare that to a similarly situated place in an urban setting, let's say San Francisco, for example, just saying, it's less than a month to see an endocrinologist compared to a year in a rural setting. So there's insufficient care for our patients in rural areas. In my service area alone of 480,000 patients, there is one full-time endocrinologist. And thus I created Blue Door Health. So Blue Door Health is a comprehensive metabolic offering to employees who work for rural health systems. At the same time, we train residents through formalized didactics and hands-on clinical experience while leaving behind obesity centers of excellence in these rural areas. Our objective is to improve obesity-related health outcomes and overall well-being from employees in rural health networks, to bridge the gap in obesity medicine as it relates to chronic care for our medical residents in rural health clinics, and to reduce per member per month costs due to obesity and its related illnesses. And this program is even more important because residents, more than 50% of residents will stay in the area that they train. This is our program overview. The initial visit, patients will see an endocrinologist. They will be accompanied by a resident, and then visits will be done either remotely or in person. We'll do comprehensive histories, we'll do comprehensive metabolic workup as well as laboratory workup, and then of course we'll address underlying issues. This is what the patient journey looks like. Their initial visit, they'll be seen by a board-certified endocrinologist. We'll do a comprehensive visit for the resident at bedside. And then every month thereafter, they will be seen by a resident. And the resident will be supervised by an endocrinologist. This is how they get their hands-on experience. They'll do their first and second virtual touch point, and at their third virtual touch point, they will see an endocrinologist again. So they will see the attending every 3 months. However, in between, they will be seen by a resident, who is of course supervised by their attending. And just for your kind of perspective, these are our CPT codes for the institution I'm currently piloting at. So what does our success criteria look like? So what are we looking for? So we're looking to reduce per member per month costs for employees who work for the rural health system by 5%. I'm looking at a 10% reduction in days lost per year in productivity. I'm looking for a 15% reduction in BMI, a reduction by 1.5% in hemoglobin A1C, and a 10% reduction in LDL parameters, and a 20% reduction in triglycerides. And you can kind of see the rest of it there. So our initial pilot is happening at one of the largest rural health centers in the country. We are currently piloting this with about 200 patients. That's what we needed for our p-value to remain statistically significant. I'm working with about 36,000 patients with that employer health plan. This is our adjunctive app. As you can tell, that's me, probably a little bit younger of a picture. This is the app that we're creating currently. We have a patient-facing app and then a provider-facing app. This is by no means mandatory, but it works for the patient. The most common thing that my patients tell me is, I wish you were with me at the grocery store. If you were with me every day, I would probably never fall off my diet. So we are creating this patient-facing app to be with them all the time. Think about it like a dock in your pocket. We are also creating a provider-facing app, not only for residents, but for early-stage clinicians who are interested in treating patients with obesity so they can have a resource. So how do we make money? This is our revenue model. We have naturally a clinical revenue generation. We have a SaaS platform revenue, which I priced at $3.99 per member per month for employees of the health plan, and 99 cents for Medi-Cal patients. Of course, I priced that very low for obvious reasons. And again, this is by no means mandatory. It's an adjunctive app. This is a SaaS platform revenue. And then, of course, our healthcare enablement and education platform. We are leaving behind a Obesity Center of Excellence. We will leave behind our didactic materials, and we will white label this program for rural centers. So what makes this program unique? And I have to admit, I struggled a little bit making this slide because there isn't really a program that exists like in this space. I'm not a telemedicine company. I am not strictly selling GLP-1s. I'm not an AI company, and I'm not really a fellowship or a training program. I'm kind of somewhere in between. So if you look at this, what are we really doing? We're doing physician education is embedded in our model. Beyond just treating patients, I'm training the next generation of doctors to deliver holistic patient-centered metabolic care into these rural areas. I'm using evidence-based comprehensive structures that deliver holistic care, whereas many of our competitors, if I could call them competitors, are mostly weight loss focused. I do frequent touch points with our residents and of course with our patients. Touch points are most often done in this space by health coaches rather than physicians that can actually tailor medications. And then, of course, continuity of care is done by resident physicians with consistent lead oversight by an expert. This platform, this program is insurance covered, where many programs out in this space today are self-pay and need a subscription. So I'm going to leave you kind of, with this thought. I've trained and I've worked at some of the most important and prestigious institutions on the planet. But I can honestly tell you that there is no greater prestige than serving a rural health system that actually needs you. Now that we are all connected, now that we have all met each other, we're all in this together. I don't want to be part of the 90%. We cannot fail. So I ask you all to help me treat patients today, train our doctors for tomorrow, and transform our healthcare system. Thank you.
Questions? Hi, I'm Ben work for the University Medical Partners, medical group, part of Standard Healthcare. How are you increasing access to endocrinologists?
Yeah.
Like, there's not that many of them, so what are the ways that's being achieved?
Yeah, that's a great question. So, and that's something that we struggle with, right? So one of the things that we try to do is we try to do a telehealth offering, right? So we're increasing access just by having endocrinologists that don't live in the area do telemedicine, so that we can actually precept these residents also from, by telemedicine. That is an ACGME. We're allowed to do that per ACGME. So that's one of the things we do. But the second is, remember in the training, right? So the residents are getting trained by an endocrinologist. So we're providing them with these formalized didactics. We're providing them with hands-on experience so that they can go out. I'm not saying that they'll be board certified endocrinologists, but at the very least, they'll be able to deliver excellent primary care to their patients with respect to obesity medicine and chronic care. That's a really great question. Yeah. Oh, sorry. I didn't mean to take over, sorry.
Thank you for a great presentation. Olaf Shaw, ACSMG solopreneur. So you had a really great slide on the outcome measures. I was wondering in terms of balance and process measures, right? We're working with residents who have very limited time in education. Have they gotten any feedback back in terms of do they feel that this curriculum is potentially giving them less time to focus, for example, on if they have another exam coming up, or other material that they're learning? Obviously, obesity is extremely important. Taking care of the problem will take care of many other ones, but have residents given feedback in terms of how this fits in with the rest of the education that's presented as part of their overall residency program?
Yeah, so I have received feedback from my residents. I must say the feedback that I have received, and I'm not biased, but the feedback that I've received honestly has been positive. The difference between this and a kind of simplistic, if you will, obesity program is we're delivering comprehensive metabolic care. So we are offering GLP-1s, for example, just as an adjunctive tool, but at the same time, we're also tapering diabetes medications. We're also tapering hypertension medications. As we lose 20 pounds, we lose 10 on systolic, right? So, we're also doing those things. So I think, certainly no knowledge is ever lost, but I have not received any feedback that this is because they're doing so much clinical care, it's been disruptive. Like I said, we do offer didactics as well, in kind of in a formalized, structured way. So I have yet to receive anything that it's disruptive. If anything, it's been helpful. We practice really evidence-based care, and that's what appears on the boards anyways. So I've actually gotten feedback that this has been helpful. So, yeah, it's a really good question, yeah.
Okay, any more questions? All right, thank you very much.